Welcome to COP TV, Communities of Practice Television, in the Department of Family and Community Medicine at Meharry Medical College. Today's episode features Dr. Earl Stewart Jr. on the necessity of training medical, dental, and public health students to be on the front line of reducing and eliminating the opioid crisis. You can visit COP TV for the remaining episodes.
One of the things that, and I shared this with many of the students who attended my Emerging Alumni Series talk, basically talked about the benefits and the challenges and some of the things that we deal with practicing in a rural community. It's no different as it pertains to the opioid epidemic. There are challenges. In rural areas, we see a lot of very disproportionate prescribing of opioids. You don't have very many patient-centered medical homes. In more urban areas, that is something that you have. In rural areas, you have a very gross physician shortage. That's one of the reasons I'm in the rural areas, because while I was a student at Meharry, I had the wherewithal to take a scholarship that would require me, so to speak, but I wanted to do it, but that would require me to return home to practice in an underserved community. And I could have practiced in the Department of Corrections, the Department of Public Health, or the Department of Juvenile Justice, or with the Department of Behavioral Disabilities within the state of Georgia. But I specifically wanted to transition into an area that needed physicians the most. And so that is rural areas. So the physician shortage is astounding in many rural areas throughout the state of Georgia, but not unlike many other rural areas throughout the United States. That's why there are incentive programs in Tennessee and in Georgia and through the National Health Service Corps nationally that are really geared toward physicians and dentists and nurse practitioners who want to go into these areas where they will be needed the most. And we are needed. But I do not think that in our town where we practice, there is a patient-centered medical home. There has been, a thought process of potentially having that in our own practice, but I often hear that, it would be too much paperwork and too much that they would have to deal with in order to get that taken care of. And I certainly think it would be a wonderful thing if, because my focus is very patient-centric and patient-first. That's not something that we see on a global scale in these small communities. Keep in mind that, as I said previously, many of these communities, including Thomaston, were bustling with mill towns and factory towns, and during the Industrial Revolution, and continued well into the 70s and 80s and even the 90s in some areas. And now, when all that goes away and these mills and these factories close down, these people are left in very dilapidated and destitute situations, and they're struggling often to find ways to cope. And it is not uncommon that we see the development of drug addiction as a way to cope, oftentimes spearheaded by some form of depression. Many of these patients have polysubstance abuse. A lot of times we find, specifically where I practice, I find a lot of hepatitis C, not so much HIV, but we see a preponderance of both with IV drug users using heroin who eventually test positive for HIV and also hepatitis C. So I'm finding a lot of hepatitis C within Upson County that I'm eventually referring for treatment. Specifically in my Suboxone patient population, but also others, but really in patients who are struggling with opioid addiction. So in urban environments, and I have had the pleasure of training in urban environments and also practicing in an urban environment before transitioning to a more rural area, you see it, but there are more resources available. You see patients struggling with drug addiction. You see patients struggling with an addiction to prescription and illicit opioids, but there are resources, maybe closer by at more prestigious hospitals, larger hospitals. We don't have very many of those resources available at the small rural hospitals that we have. There's a small rural hospital in Thomaston, and they really don't have in place any sort of program to help patients overcome drug addiction. All we really have are our stellar case managers and social workers who we can call on to say, well, hey, um, is there some way we can connect this patient with counseling? Is there some way that we can connect this patient with a psychologist or psychiatrist in the area? But unfortunately, we don't have many psychiatrists. We only have one psychiatrist, and he does geriatric psychiatry. But we've been fortunate to attract to Thomaston those who grew up in the area, went off to college, trained, and who have come back to work at a local counseling center, um, who have been a godsend for many of my patients enrolled in the Suboxone treatment program that we have, who benefit from the counseling services that are available through their expertise. And so that's a requirement for many of us who basically have the DATA 2000 waiver to prescribe buprenorphine analogs for opioid use disorder. We have to recommend to patients to get enrolled in some sort of substance abuse counseling. And I provide that information to patients at the time of establishing a contract with them for Suboxone.